Let me explain the treatment plan to ensure you understand every step.
Today's video shows the process of rebuilding anterior teeth using a fiber post. The patient presented with severely damaged front teeth. Due to extensive decay and loss of tooth structure, the remaining teeth were no longer strong enough to support a direct restoration on their own. After clinical evaluation, a fiber post supported restoration was selected. Fiber posts are commonly used in anterior teeth because they provide internal support while maintaining flexibility similar to natural dentin. The procedure begins with proper isolation and preparation of the root canal space. The canal is carefully cleaned and shaped to receive the fiber post, ensuring an accurate and stable fit. Next, the fiber post is tried in and adjusted to the correct length. Once confirmed, it is bonded into place using adhesive cement. This step is critical, as it creates a strong foundation for rebuilding the tooth structure. With the post secured, the core buildup is performed. Composite material is layered carefully to recreate the natural form of the anterior tooth. Special attention is given to contour, alignment, and symmetry to achieve an aesthetic result. Throughout the procedure, precision and control are essential. Anterior restorations require both functional strength and natural appearance, especially because these teeth are highly visible during speech and smiling. After shaping and finishing, the tooth is prepared for the final restoration. The result is a reinforced anterior tooth with improved strength, stability, and appearance. Fiber post restorations allow clinicians to preserve remaining tooth structure while providing long-term support. When performed correctly, this technique can significantly improve both function and patient confidence. Thank you for watching. This video is for educational purposes and demonstrates a common approach to anterior tooth reconstruction using fiber posts. The video presents a tiered approach to mandibular anesthesia to ensure successful numbing of mandibular molars, even in abscessed cases. Here's a breakdown of the 3 tiers. Tier 1. Standard local anesthesia techniques. Topical anesthetic jelly. Apply 20% topical benzocaine to the injection site. The key is to dry the area with a 2x2 gauze, and then cover the benzocaine-coated cotton tip applicator with the gauze to prevent it from dissolving and to aid absorption. Inferior alveolar nerve block, IANB. Administer an IANB using warmed 2% lidocaine, aiming slightly higher than usual, just beneath the maxillary tuberosity. Start with 2 carpules and allow 5 minutes for the medicine to soak in. Buccal infiltration. If the patient isn't fully numb after the IANB, follow up with a buccal infiltration near the mandibular molar. This targets buccal nerve branches and uses a local anesthetic like 4% septicaine or mepivacaine to change the pH in the environment. Tier 2. Supplemental techniques for inflammation. PDL injection, periodontal ligament injection. This highly localized injection targets nerve endings in the PDL and provides anesthesia to a single tooth. It often requires significant pressure to administer 1/8 to 1/2 a carpule of anesthetic, typically 2% lidocaine. Have an assistant ready with suction to remove excess anesthetic. Non-anesthetic pain management. Preoperative NSAID. Advise patients to take 600 mg of ibuprofen approximately 2 hours before the appointment to reduce inflammation and provide analgesia. Intraoperative nitrous oxide sedation. Administer nitrous oxide to help with patient comfort, acting as both an anxiolytic and an analgesic. Tier 3. Advanced techniques. Floor of the mouth injection. This is a last resort for highly resistant cases, targeting the nerve to the myeloid, which can occasionally provide sensory innervation to lower molars. Use a brand new 30-gauge needle and 2% lidocaine, discarding the needle immediately after the injection to minimize the risk of needle tract infections or hematoma.